Okay, we're going to go ahead and get started. Thank you, everyone, for coming today. Thank you, those at the Missouri sides, for dialing in. We're going to welcome Dr. Brent Bergen today. He's a physician here at Farrell Duncan Clinic and board certified in critical care, pulmonology, and sleep medicine. And Dr. Bergen graduated from the University of Oklahoma College of Medicine, completed an internal med residency at the Texas A&M, and had a critical care fellowship at St. Louis University.
Right. Yes.
Dr. Bergen is going to present today on overdoses. Please welcome Dr. Bergen.
Thank you. Well, Cassandra asked me they contacted me last June to do a talk, and then Monday I was still working on slides. My nurse pointed out that I put the pro in procrastination. But actually, for a while, I didn't know what I wanted to talk about, and then one day it was kind of a fun overdose. Many overdoses have just gotten to the point where they come in, they sleep it off, we send them up to the psych floor, and it's kind of boring. But someone with a heart problem came in with a beta blocker overdose, and it was actually a little more fun to manage somebody a little unstable, having problems with the medicine, which prompted me to pick this topic. I didn't even know what topic I was going to pick, and I was originally supposed to talk a couple months ago. She put it off, I put it off, and so I came up with this. And what you'll find right now in school, you're testing all the time. You do something, you test. You study this, you test. Well, when you get out, when you study something, it's for the benefit of your patients and for your own benefit, and it's much easier and a little more fun, if test studying can be fun, to study the stuff that you're working with. And when that patient came in with beta block overdose, I went back and read stuff and remembered some things that I'd forgotten about mental status changes and a few other effects from beta blockers. And also, when I was in medical school, the big overdose was tricyclics, because everyone was on them. It was before Prozac, it was before, we had Xanax. And tricyclics really cause unstable patients. So we dealt with and studied overdoses all the time. Well, Prozac and the SSRIs have made overdoses boring because it's really hard to kill yourself with an SSRI. And you can tell I'm an intensivist because I call that fun. Psychiatrists can worry about their emotional state, as Charlie Sheen did too. It's also easier because we have better detection techniques. We have faster labs, faster turnovers on our lab results. Recently, there are some new drugs. We'll talk a little bit about some of the synthetic marijuanas and bath salts, which are making things a little more interesting again because they're a little more problematic. Some boring numbers, lots of calls to the poison control. That's the best. Oops, maybe it's the next slide. The best resource is call your poison control. If you don't know what's going on, you can ask them questions. They have all the latest information. Generally, the mortality is quite low because most people do what I used to call underdose. They don't take enough to do anything good. But about a quarter of them end up in healthcare facilities, and about 1 in 16 or so get admitted. So it's important. And I was very surprised by this last statistic. Think about that. In 2008, more people died from overdoses than car wrecks. That means our cars and roads are getting safer, but our druggies are getting dumber. The most common overdoses are analgesics, about 12%, sedative hypnotics, about 11%, and then antidepressants, about 6%. Middle-aged adults are the biggest group of people that overdose, but the people at the highest rate is young adults. Most of you are in that age range. And first of all, just take the general approach. You have to be thoughtful like these people here. I don't know if anybody remembers that show, but they were always thinking, what'd they take? What clues do we have about what they take? What bottles may be laying around? What does their family say that they're on? What did the EMS or the police or whoever found them say was around? What smells did the people notice when they were there? Is it acute or chronic? We'll talk a little more later about a few of these things, but people can come in with problems. Or is it acute, and how acute? Did they take it all at once? Have they taken things over a few hours? Because that will affect the levels we're drawing. and look at their prescription medicines. The interaction is actually easy now. We all have apps on our phones now. We can just put in there and list their medicines and hit the little tab for interactions. It'll pop up everything. So knowing what prescription medicines and what over-the-counter medicines they're on are important. Was it accidental or intentional? That's a important piece of information, mostly after you get them through it, because that really is how you're going to manage them. Is it accidental? Are they demented? Are they messing up their medicines? Do they have cataracts, vision problems? They can't tell the difference between their pills. They take the wrong pills, or they forget, I didn't take my morning medicine, so they take their morning medicines again. I learned about this in medical school. I had an ear infection, and so I had a prescription for erythromycin QID for 10 days, 40 pills. 10 days later, I thought, well, I did a pretty good job. I took those medicines. I remember to take them. I looked in the bottle. There were 6 tablets. I cleaned my car later in the day. There were 4 tablets on the floor. So there I was in medical school. I should have been bright and alert and not demented and had good vision and all those things. I still couldn't take a medicine 4 times a day. It's my only pill. So it's easy to mess up your medications. In the initial assessment, you can get a lot of information just from the things that the nurse will tell you. The vital signs, the mental status. You just walk in a room and look at these things, the temperature, pulse ox, EKG will probably be hooked up by the time you see them. You can look and see if there's any ectopy or problems going on there. A little bit more supportive care, just the basics. Get good IV access because they may crash on you. You need to have good access for resuscitation. If their mental status is altered, you can't be faulted for intubating them. Even if their blood gas looks fine and you think, oh, their pulse ox is fine, they look good. No one will fault you for intubating and over-treating because many of these drugs, as they get metabolized, people will deteriorate pretty quickly. So intubation, ventilation, resuscitation, ABCs, just like ACLS. This you'll hear over and over and over, charcoal. Everybody should get charcoal unless they inhale the volatile. Because some of these drugs don't get absorbed right away. They may take extended release tablets. Some of the drugs metabolize through the GI tract, so clearing them with charcoal is important. Removing clothing and cleansing skin. This is more related to some of the exposure, some of the things they may get poisoned with, but some of these drugs and chemicals can be absorbed through the skin, so it's important to remove those things and get them cleaned up. Antidotes. We'll talk more about some of the antidotes. These are 3 of the more common ones that we'll talk about it later. And then there's ways to enhance elimination. Some drugs are cleared by hemodialysis, so it's good to know which drugs those would be. And then there's the most important thing. If you learn nothing else, just know to call, because they can answer the questions that are important. Some of the things, when someone rolls in, you don't really know a whole lot about them. They may or may not have had a bunch of empty pill bottles. They may have a history of taking things. A few other things, or these are the big 3 things we think about when someone comes in with an altered mental status medically. Trauma, well, there's a head injury, things like that. But Wernicke's encephalopathy is someone who's a chronic alcoholic. Do they take opiates? The group of people that takes the most opiates in this country is the elderly. It's remarkable the number of people that are on Percocets and Starbacets off the market now and other painkillers. And hypoglycemia. Always check the glucose. Everybody. If they have altered mental status, things don't look right, check a blood sugar. Hypoglycemia and hyperglycemia can cause lots of problems. But don't forget trauma. These people aren't going to provide a good history with altered mental status. So you'll never be faulted for getting a CAT scan of the head if you think there may be any element of trauma, and you'll never be faulted. In fact, you probably should put seat collars on all these people until you know better. Put a hard seat collar on anybody that was found down. They could, even if they passed out from their drugs, and clip their forehead on the edge of the table on the way down and end up with a C1 fracture. Look for other clues. Look through their pockets, look through their wallets, track marks. Just be very careful, though, when you're put your hands in someone's pocket, there could be needles or sharps or something like that. So have the nurse do that. She gave you a dirty look for that. And any other paraphernalia that may give you clues to what they've been taking. A few, the vital signs, going back to the vital signs, they can give you some clues. If they're physiologically excited, there are certain things to think about. Cocaine, amphetamines, things like that. Physiologic depression, think about things that would depress them, especially the opiates. Alcohol also. Mixed physiologic effects. The big one there, if you're taking a test, think of aspirin. If it doesn't make sense, think of aspirin. Now, there's a few tables. These are mostly from Up to Date. I don't know if copies of the tables have been made for you. In the critical care boards, and I think on the internal medicine boards, bitter almonds and cyanide is always there. I've never in my life seen a cyanide poisoning, but it's always on a test. Garlic, the smell of garlic and arsenic, that's there. Now, selenium in the left column should be in the right column under arsenic organophosphates. I did this with Keynote and converting it to PowerPoint. A few of the margins changed. In freshly mown hay and phosgene. Phosgene is the World War I nerve gas, but it is used widely, especially in the pharmaceutical industry. So that still could happen. Those are common critical care boards questions. The medicine boards, the bitter almonds and cyanides, almost always there. Now, quickly memorize this. Again, these tables are available. If you think about mydriasis, dilated pupils, fight or flight, stimulating things that are going to get you going. That's what's going to be in that column. We'll talk a little more about serotonin syndrome later. That's something that's getting a little more common and can be seen at all sorts of different levels. And so I would recommend that sometime if you're on either psych or a general medicine rotation, learn about that because so many people are on the SSRIs. Meiosis, small pupils. We're all kind of familiar with that. The person that's on narcotics, a bunch of pain medicines, small pupils. Nystagmus, remember that's twitching of the eyes, essentially. They'll jerk back and forth or up and down. One of my fun stories was nystagmus. Horizontal nystagmus is common. It could be drugs, it could be minor pathology. Vertical nystagmus is bad brain pathology and PCP. Now, PCP is an anesthetic. People on PCP can do superhuman things, and I've heard those stories, basically because they don't feel pain. And so they can be overwhelmingly strong. In medical school, I saw a video of someone who was in steel reinforced leather restraints on PCP. And he pulled his hand out of his arm out of one of the restraints, and his hand was still in the restraint. A friend of our family's was a former policeman in Los Angeles County, and they're taught when they see vertical nystagmus, assume it's PCP, shoot them in the chest. Doesn't matter what's going on, just shoot them in the chest. Because their policy is don't let them harm you or anyone else. PCP is a bad problem in Los Angeles, apparently. I don't know. Police are taught that here. Again, there's about 4 slides that are just big tables. We'll kind of skip through them a little bit. Seizures. When you see somebody seizing, it's a potential overdose, treat with benzodiazepines. There are a few seizures with tricyclics, with theophylline, and one other where it would be detrimental to use phenytoin. So use benzodiazepines. You won't go wrong. Benzodiazepines also help with the twitching and things. It may not be a seizure, but that's the only way to treat a seizure and a potential overdose till you know absolutely what's going on. Rigidity, Parkinson's, probably the one situation that you really need to be aware of is if you're taking care of nursing home patients. Now, the government has really cracked down on it, so it's not as much of a problem, but many nursing home patients were being sedated with tricyclics, but the one drug that slipped up on us is metoclopramide or Reglan. It'd be on MARs for nausea or something like that, and people would be getting them, and they would come in, grandma is frail and elderly and has a very low body mass index, and she would come in rigid or unresponsive, and it was from the Reglan. The government has picked up on that and watches nursing homes very closely about drugs and over-sedating and over-treating people, because if you really think about the situation, you got I think 80% of people in a nursing home related to dementia, and that means they wander around, they don't follow instructions, they don't stay where they're supposed to be, and when they get over-sedated, they're easier to manage. So it's a slippery slope into just knocking people out and leaving them there. And Reglan's metoclopramide is on the boards. It's a test question. It's something you need to be aware of for your patients. Somebody comes in with weakness and paralysis. Now, you may see these in the clinic. It can be very subtle. There can be heavy metals in well water, toluene, and some of the solvents. People have hobbies. They like to paint cars. They clean auto parts and things like that, and they're exposed to those things. And that can actually present pretty subtly at times. Mental status alterations. Again, this another table. Just kind of know where to access this stuff. These are from Up to Date, which is an electronic medical text. It's probably one of the better medical texts out there because it's constantly being changed. I was told in medical school when I started that what you're learning today, in 5 years, half of it will be obsolete. That's probably accelerated. It's probably down to 3 years now. So what you're learning today, by the time you're sitting for boards, half of it I'm lying to you. I'm not lying because I don't know that I'm telling you the wrong thing, but the information changes fast. Skin alterations. That was just one more of these boring tables. The disulfiram reaction and disulfiram and ethanol. Do you know what that? Anyone know what that is? It was marketed as antabuse. Yeah. And it makes people feel horrible when they drink. They flush, they get nauseated, they just feel miserable. A significant percentage of people from Southeast Asia and Japan have a deficiency in the enzyme will do that. And so they don't do well when they drink alcohol. Temperature alterations. Somebody comes in very hyperthermic. Think about muscular activity, rigidity, things like that. Drug withdrawal. That's one of the cardinal signs of alcohol withdrawal is a fever. Let's go backwards. Hemodynamics. Again, just a table of stuff. Respiratory alterations. I had one of my attendings tell me if I could have one piece of information about a patient to tell you if they were sick or not, it'd be respiratory rate. It wasn't anything else. But you think about that, that really makes sense. If their respiratory rate is very low, that tells you a lot. If it's very high, it tells you a lot. Probably the one thing to think about with elevated respiratory rate is aspirin, both acute and chronically, because these people come in and they won't give a history of overdosing it, but there are so many products over the counter. I think worldwide there's probably over 100. I think 100 products. Also on here is iron. If you're going into pediatrics, that's the big one for the kids because they get into mom's neonatal vitamins. As an adult physician, I've never seen that. Do not see children, do not want to see children in the hospital. Basic tests. everybody gets an EKG. Look at the heart rate. Look at the character of the QRS complex. Are they bradycardic, such as a beta blocker, calcium channel blocker, DIG, opiates will make them bradycardic. If someone is going through withdrawal, it may accelerate. Supraventricular tachycardia, think of the stimulants, cocaine, amphetamines, alcohol withdrawal. Those are all stimulating. So if someone goes into VTAC, cocaine, amphetamines, and theophylline. Theophylline we used to prescribe like candy and COPD and asthma because we didn't have a lot of good medicines. I grew up before Advair. Advair made things a lot easier. I shouldn't tout a drug in a talk like this, but when they came out with the long-acting bronchodilator and steroid combinations, asthma management really changed. Don't forget caffeine, pseudoephedrine. People don't think about how much caffeine they consume. Not unusual when I'm taking histories of people, and I'm usually thinking more about their calories that they're consuming, but there's a lot of folks out there that drink 2 liters or more of soda every day. People will drink a pot of coffee or more. I think as medical students, we've all been guilty of too much caffeine at one time or the other. Look at the QRS complex. Any cardiac drug can affect the QRS complex. Antidepressants, antipsychotics, and even antibiotics, penicillin-based drugs can affect the QRS complex. Get a chest x-ray. Opiates can cause pulmonary edema. Look to see if they've aspirated anything. They've overdosed. They generally have an ultra mental status. What else may have happened to them? They may have thrown up. They may have aspirated. They may have swallowed something they shouldn't have. It's good information from some basic tests that we almost always get. CT's up there again. If you're not sure, can't be faulted for checking a CAT scan to look for a subdural hematoma or an acute injury. Tox screening, our urine drug screens are pretty good now, and they're pretty comprehensive. They don't get bath salts. I'll talk a little more about that later. So bath salts is usually a clinical diagnosis. Checks salicylate and acetaminophen levels is routine, and a blood alcohol. People often co-ingest, especially in suicides. They'll wash down whatever they're taking with alcohol, or they'll drink some alcohol to get the courage to overdose. Basic lab work that would normally get, lactate's not typically something that we normally would order, but can provide useful information about perfusion. Getting the blood gas and the basic chemistries, look at the anion gap. Wide anion gap that you can't explain. Think about aspirin, methanol, and ethylene glycol. So we don't get ethanol and methylene glycol levels. We don't have those, but they cause wide anion gaps. Isopropyl alcohol makes the BUN and creatinine go up acutely. So people, I think I have teenagers. There's, what do they call those parties where you go into grandma's cabinet and you just grab everything and start swallowing pills and drinking whatever you find in the medicine cabinet? That's what teenagers are doing. You have a teenager?
No.
You don't want one, do you?
God.
Other measures, again, decontamination with charcoal. Always, 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 unless there's a volatile of time. Okay, this is my time-killing slide. Antidotes. Now, this is not a comprehensive list of antidotes, but we're going to quiz here. What is N-acetylcysteine the antidote for? There you go. Digibind. That should be kind of easy. Digitoxin. Ethanol. Methanol. I heard methanol. Or ethylene glycol, which is antifreeze. We may leave that out if the neighbor's dog's a problem. I didn't say that. Atropine. What's atropine an antidote for?
Organophosphate.
Very good. Excellent. Dimercaprol. Heavy metals, right. Arsenic, mercury, gold, lead. What medication, or who would be taking gold? Rheumatoid arthritis. Very good. It's not a whole lot of people are on it anymore since we have the immune modulated ones like Enbrel, but few people are still on it. Flumazenil, Benzos, very good. Penicillamine. Yes, any of the heavy metals, copper, you want them. Amyl nitrate, whippets. That's what whippets are, amyl nitrate. So, what is the antidote for? This one's the bitter almond smell, cyanide. So that question, I've seen it so many times on so many tests. I've never seen the patient. Protamine sulfate. Heparin, very good. So where are we? Defuroxime. Iron, yeah. And naloxone. Opiates, very good. And vitamin K. Warfarin, right. And we have some new medicines that hopefully will someday supplant warfarin so lawyers don't sue it out of existence. Things to do to enhance elimination, alkalinize the urine. That's a big one with tricyclic overdoses and a few other drugs. Dialysis, you just have to be familiar with which drugs can be removed with dialysis. Some get dispersed so diffusely through the system, the dialysis is useless. Hyperbaric oxygen with carbon monoxide poisoning. And NG suction. There could be stuff down in the stomach that they haven't absorbed yet. People take a lot of opiates, their bowels slow down, they're not absorbing things. Remove what else they could still be absorbing. Specific treatments, we can talk a little more about that, about cardiac dysrhythmias and seizures. But when in doubt for cardiac dysrhythmias, it's sodium bicarb. For seizures, benzodiazepines. All right. 417. You live in I guess you don't all live here right now, but you're in a special place. A drug named after the area code. We should be proud, even though I don't think we're leading the nation anymore. We lump these together, amphetamines, meth, and bath salts, because they're basically the same to us. Urine drug screen will pick up the amphetamines and meth very well. Bath salts will not. Bath salts is a clinical history, and the scary, frustrating thing about bath salts is these others clears the system pretty quickly. We had people in the ICU for several weeks with the bath salt overdoses. They're stimulants, hyperalertness, hypertension, tachycardia, mydriasis, diaphoresis. Does anybody know when and how meth was developed initially? Who first cooked meth? It was German scientists. They wanted to make better soldiers. Well, it makes them aggressive, makes them hyper alert. They stay awake for days. On the surface of it, that sounds like the ideal soldier. Makes them angry. Good features in somebody who's in the middle of a fight, I guess. Meth was over the counter for the time. Bath salts are an attempt to chemically alter and stay ahead of the law. When Congress rewrote the laws a little bit. When I was in college, the federal law was very specific. They would define the chemical, and they would say this chemical is illegal. Well, then chemists would come along, add a nitrogen atom, and it would be a new chemical, and it would no longer be illegal. So that's where ecstasy and a few drugs like that came from. I think about 10 years ago, Congress wrote some laws about doing that so they can kind of try to keep up with the chemists who are smarter than our congressmen. There's no congressman smart as a chemist. The stimulants alter mental status. People get anxious, agitated, they get very violent. Police and sheriff's deputies will say it's hard to prosecute some of these meth dealers because they're so violent that no one wants to be a witness against them. When it gets bad, they may have seizures, psychoses, hallucinate. Bath salts are chemically, they're called cathinones. They add a beta carotene to change it a little bit, but essentially we're still dealing with meth. How we treat? We sedate them. These people are agitated. They may seize. Calm them with benzodiazepines. Control their airway. Succinylcholine you don't use. forget chemically why, but basically it can react with the meth and they can go into cardiac arrest. So hypertension, nitroprusside is usually the drug of choice. Hyperthermia, if they have a fever, it's not because they have a fever, it's the increased muscle activity. It's not an infectious fever, I should say. So we need to calm the muscle activity down. So antipyretics like Tylenol, things like that are not going to be effective. So we use benzodiazepines for the hyperthermia. Cardiovascular collapse, we resuscitate them. Again, sodium bicarb. It's hard to go wrong in overdoses using sodium bicarb with cardiovascular issues. Some of the complications, the rhabdo is from the increased muscle activity. They can get cardiomyopathies, lots of dysrhythmias from the stimulatory effects, strokes, acute tubular necrosis. Now, pulmonary hypertension is rare. I have one person that St. Louis agrees probably got pulmonary hypertension from Ritalin. She was on Ritalin after a head injury. And it's a very weak analog of amphetamine. Some of the other analogs, MDMA-X, that was huge when I was in college. You can figure out when I went to college if you know your history of drugs. MDA was the love drug. Basically, people will get so stimulated on these drugs that they'll be awake for 18, 24 hours. They'll go to these parties called raves where they just kind of wear out their hyperactivity, and then they crash. PMA was called death. I don't know if I would, even if I was trying drugs, I don't think I'd want to try a drug called death. It's kind of a giveaway. PMA is called death because there's a lot more cardiac arrhythmias. It prolongs the QT interval, which with time you'll learn more and more that antidepressants, many of them will prolong QT, so they can interact with other medications that someone's already on, and they'll go into cardiac arrest. K2 is a synthetic marijuana, and again, this is another attempt to take THC and one of the other. They'll take the THC and one other chemical and then alter it, put a carbon on it, do something to make it a little bit different, and then market it legally. And if you were here, I think a year or two ago, a few of our, we don't really truly have head shops anymore, but a few of the convenience stores were busted for having this. Other countries, it's still legal. And they call them herbal highs. Red eyes, tachycardia, anxiety. However, as opposed to marijuana, the concentrations can be very high, so they get some different effects. They can be very aggressive, paranoid, hallucinate. We've had people in our ICUs for 10, 15 days because they're just completely out of it mentally. They're so agitated and out of control that many times they're on the ventilator for quite a while. There have been a few reported deaths nationally. This one doesn't show up on drug screen. There's about 60 different metabolites that can be detected. There's a lab. I don't know if it's associated with the university. It's in Detroit. If you really want to know and had to know, you can send it up there and they can tell you. They're trying to stay ahead of the chemists who are developing more and more different varieties. Cocaine. Now, if you happen to be a Pulp Fiction fan, you'll remember that Mia Wallace was actually snorting heroin. But I like the picture. It fits right here. It is the most potent natural stimulant. It's extracted from the Erythroxylum coca plant. Grows in the Andes, and it has beneficial effects. In the Andes, the Indians will brew it like tea. It's a little bit stimulating, kind of like caffeine would be for us, because it's in very low concentration in those plants. They will chew on it. And if you know your geography, the Andes mountains are very high. And people at altitude travel at altitude at 15, 17,000 feet or however high some of these villages are. To get from village to village, they can't physically do it. They chew on these leaves, it reduces the pulmonary edema, and they can travel from village to village at altitude. Cocaine can also be used as a topical anesthetic. People have the right or the wrong allergy profile. We'll use it to numb the nose for procedures. So it does have some beneficial effects, but when it's concentrated, it's almost all negative. It's very sympathetic. Sympathomimetic. It affects the calcium channel blocker, which has an anesthetic, and it's very excitatory and stimulating. And it's easy to absorb. Any mucosal surface. We'll talk a little more later about body packers, but they can get in trouble. Cardiovascular, very dose-dependent, increased heart rate, get very tachycardic, arterial vasoconstriction, hypertension. These people can come in with hypertensive crises, increased myocardial demand. This is the drug to think about if a question on a test was somebody who was having a myocardial infarction and they were overdosing. This is the drug I would pick. They get agitated, develop seizures, coma, headache from the elevated blood pressure, intracranial hemorrhage. If they become hyperthermic, mortality is very high. Generally, we can calm them down, but if they start having a fever, it's tough to turn them around. Pulmonary, they can get angioedema, pharyngeal burns from smoking it. Anybody remember Richard Pryor? Pneumothorax, pneumomediastinum, that's from snorting. If you snort hard enough, sometimes if you're susceptible because you have some emphysema, you've been a cigarette smoker, you can collapse a lung, get air tracking down to the mediastinum. It can also cause bronchospasm. A few of the cocaine syndromes. But on the other PowerPoint, this one came out too pale. Again, Pulp Fiction. She was doing heroin. Chest pain syndromes. This is not angina. They'll come in describing pain that sounds very much like cardiac angina, but we treat it with benzodiazepines. Calm down the stimulatory effects of the drug, and the chest pain clears. Crack lung, if they're smoking crack, they get hemorrhagic alveolitis, and the lungs will just fill up with blood. Body packers. Think about that situation and use GI decontamination, charcoal. They'll put it in balloons, they'll put it in baggies, and they'll swallow it to smuggle it somewhere. And if one of those balloons breaks, they start absorbing the drug. If you're a fan of NCIS, there's a delightful scene in one of the shows, and I couldn't find it to put the picture on the slide. Paint huffing. Now we're close. This was huge 20 years ago. It has faded quite a bit. It sometimes is the gateway drug for kids because you can sniff glue, you can get paint. They prefer the metallic colors, gold and silver, because there's more toluene, so there's more of a high from it. Spray it in a bag or a can, put your face on it, and sniff it. 11% of high school seniors have reported that they've done this. Studies with high school seniors are always difficult because they lie a lot. They lie more than adults, probably. But it's probably believable that somewhere in that ballpark, people have tried it. Sometimes it's the first drug abuse for kids because they can access it. Peak incidence is about 7th, 8th, 9th grade. They get a brief rush or high. It only lasts a few minutes. And one of the dangers of this is during that high, there's increased heart rate, increased myocardial demand. And for whatever reason, paint huffers like to run. And if they exert themselves hard while they're having all these cardiac changes, they can just drop dead. And so kids sometimes will just drop dead from paint huffing. It's volatile hydrocarbon. It's easy to absorb. Neurons are very susceptible. It's generally a depressant, but kind of like a low dose of alcohol. You kind of feel good. Yeah, it's a little bit stimulatory. When they come into the ER, slurred speech, ataxia, disoriented, very confused. When on a cardiovascular, the QT changes, that's usually what leads to the death, because think about that. Think of your QRS complex. If QT prolongs and then you start running, so your heart rate goes faster, the QRS complexes come together. Well, if the QT interval then runs into the next QRS complex, it leads to VTAC. So it's a very dangerous drug. A few other things, going back to the picture. If someone has eczema all right here, and especially if they have metal flakes in their ears, but people get dermatitis frequently from that. All right, this is where I make the awkward switch from the amphetamines and stimulatory drugs to something different. So I can't think of anybody more awkward than these two guys. The serotonin syndrome is very common, and we can see this in all sorts of levels. And in the clinic, it can be easy to miss because people can manifest very little signs and symptoms. My wife was on a SSRI to help treat the side effects when she was going through breast cancer treatment. And she was confused. We couldn't figure it out. Stopped the SSRI, and she was no longer confused. So it can be very subtle. And it bothered the kids tremendously because she normally remembers everything. It can be life-threatening, but that is very rare. Like I said, it's getting kind of boring to treat the overdoses. The classic triad, mental status changes, autonomic hyperactivity, neuromuscular abnormality, is actually becoming an exception as we're learning more and more and seeing more about it. This is a situation where it's just clinical history. The lab work, nothing to be gained. People know they're on these medicines, so doing a drug screen isn't helpful. It doesn't mess up the electrolytes, doesn't really affect the EKG much. Some of these spectrums, which you can look at yourself, are more of what we see. And the treatment is just stop the offending drug. Now, someone comes into the ER and they're really confused, really hyperactive, benzodiazepines until they kind of get through it. Tricyclics, people still are on tricyclics, but nowhere near the rates as they used to be because of the SSRIs. They may be sedated or confused. This is the one where the cardiac effects are what scare us because it affects the QRS complex. They get tachycardic, they get hypotensive, anticholinergic effects are what we see clinically, dry mouth, dilated pupils. Here, tricyclics show up on drug screen, get an EKG, get a glucose. Again, someone comes in with altered mental status, always get a glucose, check their electrolytes. And this is the classic EKG. Notice that the QRS is widened, and it's the second half of the QRS that's wide. It tends to extend beyond 100 milliseconds. It tends to be right word of period, the second half. The S wave is deep. And the R wave is greater than 3 millimeters. So the R wave's big, QRS widens. Now you can see changes like this with electrolyte abnormalities and hypoxia and things like that. But that shape is classic. Treat this with bicarb. Treatment, bicarb. People with tricyclic overdoses tend to have an acidosis. They tend to have the dysrhythmias. Bicarb is the only treatment for the dysrhythmias in a tricyclic overdose. The other drugs that you might use, like amiodarone, completely ineffective. If they're agitated or having seizures, benzodiazepines, this is one where phenytoin is ineffective, not going to stop the seizures. Flumazenil, sometimes when you come in with an overdose, you're kind of wondering what they took, and you give them some naloxone, and they wake up, probably an opiate. You give them flumazenil, and they wake up, maybe some benzos. Well, this would be a dangerous situation to give them flumazenil because it would lower the seizure threshold. People with tricyclics will begin to seize. If problems were refractory, if you give them the bicarb, and they're still having arrhythmias, magnesium lidocaine might help a little bit. I didn't get to the picture. I better speed up. Beta blockers, this is what precipitated me to choose this topic, because I had a patient come in with this. It's very uncommon to die with it, but they can be problematic to manage because of the prolonged hypotension and bradycardia. Co-ingestion, always think about co-ingestion in any overdose, but when people are co-ingesting or people are overdosing on prescription medicines, they're probably on a bunch of other medicines too. So always think of other things that can be problematic. Beta blockers sometimes are slowly absorbed, so their problems may get worse over time. Get the usual labs, management, bicarb, ABCs. Probably the take home with beta blockers is the mental status changes. It's not from low perfusion, because other overdoses with calcium channel blockers or other antihypertensives do not have near the mental status changes that beta blockers do. Now in the clinic, beta blockers, people are kind of depressed. It reduces their energy level. So it's an effect kind of across the board in any dose. Calcium channel blockers are much more likely to be lethal than beta blockers. In fact, if you look at that first statistic, 38% of deaths from overdoses with cardiac drugs are from calcium channel blockers. And that's probably mostly because they're such potent vasodilators, it's hard to resuscitate them. And also think about the sustained release preparations. Most prescription calcium channel blockers now are sustained release, so they can keep absorbing and the levels can stay high for a very long time. Hypotension, bradycardia, and heart failure, the things that you would expect. Same initial resuscitation as any other overdose. Some of the specific therapies: atropine for the bradycardia, calcium gluconate. Well, they're blocking the calcium channels. Let's fill them with calcium, try to overcome that. Glucagon is another antidote, can increase CAMP. Insulin and glucose. Again, this is something that I just would not have known until I did these slides. Giving insulin and glucose has a positive inotropic effect. The last line is when you're desperate. All right. I made many more slides than necessary for an hour-long talk. We'll go through a few more topics. Alcohol intoxication. On the left, this is what we're told happens when we drink. And on the right is what really happens when we drink. 15 to 40% of unselected ER patients have an elevated blood alcohol level. Now, this is just a random study, people coming into the ER. So they may be coming into the ER for something completely unrelated to their alcohol, but it tells you how you end up in the ER, besides being my son, is that drinking leads to doing things that lead to poor choices that lead to ending up in the ER. They may come in with altered mental status, think of all the things, always check a blood alcohol. And this is some of the effects. Having a couple drinks actually is kind of nice. A little euphoric, little defects in coordination, attention, cognition, but you notice we can still drive up until the top end of that. So we can be a little uncoordinated and still be legally allowed to drive. As you drink more and more, you just get more slurred speech, ataxia, impaired judgment. Blood alcohol greater than 0.3% in an alcohol-naive person many times can lead to death. Last week when I was taking call covering partners who were working in the ICU, one night we admitted someone with blood alcohol of 0.66 and another one with a blood alcohol of 0.72, I think it was. That is dedication to a craft. You can't get to those levels and walk into an ER unless you're good at what you do. Benzodiazepine overdoses, they're pretty easy to deal with. We just have to support them. We have to watch for withdrawal, this is the use of benzodiazepines. There's 50 different agents. They can treat anxiety, treat seizures. Again, we use them in overdose. We treat alcohol withdrawal. Low dose can be used for insomnia, but there are better choices. Be careful with propylene glycol. Somebody's receiving a lot of IV diazepam or lorazepam. They can get toxicity of propylene glycol. Flamazanil, which you probably know a little bit about it, it's a competitive benzodiazepine antagonist, but it's very short-acting. Someone could be on diazepam, which is very long-acting. You give them flamazanil, they'll wake up, you walk away, and go back out. Be very, very careful using that. Opiate toxicity. It's from the poppy plant. It's natural, it's synthetic. It was legal. It was over the counter. Back, little history note, back when we abolished slavery, we could no longer enslave African Americans, so we began enslaving people from China. It's not really going to be in your history books. When they came over from China, they brought the poppy, they brought the opiates. People were using it recreationally. Back then, it was beautiful to have big pupils. So women especially would then take atropine so they'd have big pupils if they were taking opiates. All these drugs were over the counter back then. It's very different, and we're having more problems with drugs now. I'm not going to go into the politics of it. But anyway, the opiates were then, back in, I think, 06, they decided that you had to have a license to prescribe opiates. Causes left altered mental status, myotic tiny pupils, decreased bowel sounds, low heart rate, low or hypoventilation. Always check glucose, and again, I'll repeat that over and over because that's important. A few of the drugs have very specific toxicities. Hydrocodone tends to be paired with acetaminophen. So if you get a urine drug screen, you see a hydrocodone, make sure you get an acetaminophen level. The acetaminophen is more likely to kill them than hydrocodone. Fentanyl tends to be very short-acting, will clear pretty quickly. Dextromethorphan, that's the DM and cough syrup, so you can get it over the counter. The reason that dextromethorphan is over the counter because it's always paired with stuff that will make you sick and throw up if you overdose on it. So it's rare that you can overdose on dextromethorphan. Some other toxicities, meperidine, Demerol, not even available on a hospital formulary anymore because of the seizures and problems they can cause. Methadone is used to try to get people off opiates because it's the longest acting. It can cause cardiac problems. Tramadol. Tramadol is not an opiate. It came out, it hit the pain part of the opiate receptors, and we thought, this is going to be a great drug. It's safe. We can prescribe it like candy. It's a great painkiller. Well, if you take tramadol in a high enough dose, it overwhelms the receptors, and you get the opiate effects, the euphoria, and those other things that the drug addict is after, and it can cause seizures at those levels. You would deal with the hypoventilation, intubate, ventilate. There's a picture of pulmonary edema. That's very common. When you see pulmonary edema in an overdose patient, think about aspiration, think about opiates. Body packers, it's a common problem. Think about the adulterates. Crocodile is named that because of what happens to the skin. The dealer who's dealing illicit drugs wants to thin it out. There's more profit if I have this much heroin or this much morphine. I can thin it out with something, and then I'll have this much. I'm going to sell more. Well, they can make a real, what's the right word, less potent opiate to dilute with, it's called Crocodile. They use lighter fluid and gasoline to make it. Well, then they're putting lighter fluid and gasoline into a drug that people are injecting, and it necroses the skin. And these are the two of the least gruesome pictures I found. I saw some pictures where you could see the bones in people's arms. I saw pictures with people with no faces. And so, and with IV drugs, we also have to think about cellulitis, infections, endocarditis, and other problems. Aspirin poisoning, multiple systemic effects, hyperventilation, hypoventilation. And if you want to go back to first year, I put Krebs cycle on the bottom there. If anybody wants to throw tomatoes for even bringing up Krebs cycle, I can certainly understand. Important thing to know about aspirin is it stimulates the chemoreceptor zones for nausea and vomiting. So people who are overdosing will have like GI symptoms. So don't really think about that with aspirin. It's metabolized in the liver, but you can overwhelm the liver's ability to metabolize. So then the rest of it's being excreted by the kidneys, which happens very slowly. Tends to form bezoars. So again, GI decontamination is very important here because you got this big blob of aspirin that hasn't been absorbed yet that's probably tracking down their GI tract. If you can clear it out, you can help them out quite a bit. Tinnitus is common, vertigo, nausea, vomiting. Remember the chemoreceptors for nausea and vomiting. If they're developing pulmonary edema or coma, the mortality is significantly higher. Again, GI decontamination, important. This is one of the drugs. Think about hemodialysis. This is probably a test question. Indications for hemodialysis: altered mental status, pulmonary edema. The kidney function is poor, so that they're not clearing because you've overwhelmed the hepatic clearing. Levels greater than 100 or 7.2 millimoles, or any kind of clinical deterioration when you're already supporting them, things are going bad or badly. Acetaminophen, most widely used analgesic in the world. It's combined with all sorts of other medications. People may not be aware of how much they're taking. Usually very safe, but it can be quite toxic in big doses. And I did the math on this. To get to 250 milligrams per kilogram, I would have to take, I think 50 extra strength tablets, which to me sounds like a lot. That's like a bowl of cereal full of tablets of Tylenol. But I guess if you're really trying to knock yourself off, you're going to just sit and swallow. And again, people are chasing with alcohol. However, in acute ingestion, alcohol does not increase the risk of hepatotoxicity from Tylenol. It's really only in chronic alcoholics where alcohol increases the toxicity. These are some of the different stages based on the levels. We're running out of time. Gamma hydroxybutyrate, or the date rape drug. It is the perfect drug for a date rape drug because it's potentiated by alcohol. People don't really feel any different on it. They don't really lose consciousness, but they're completely amnestic, so they can't be a good witness. Originally marketed for bodybuilders. Can be slipped into drinks easily. I told my daughter when she went off to college, you stay in groups of 3 or more, you buy bottled beer, and they open it at the table. You don't drink anything that you don't see mixed. Because it's so easy to slip it in. There was one of the clubs downtown, one of the bartenders was doing this. A lady that works here came in, she woke up, she had bruises on her flanks in the shape of hands. So they were trying to drag her out of the bar. She got lucky because she got sick. She started vomiting, and the bartender, she was probably not drugged by the bartender. The bartender called an ambulance because she was vomiting. But whoever had roofied her was trying to pull her out, and he just kind of disappeared into the crowd. It's treatment for narcolepsy. I'm also a sleep physician. It puts people out and helps treat narcolepsy because it consolidates sleep at night. They get better sleep. It's very tightly controlled. And I had 2 patients on Xyrem in my entire practice. I told them, don't tell anybody. You got the date rape drug in your cabinet. This is dangerous. Don't tell anybody. One of them's wife works with the other patient. They got to talking, and now they both know that they have Xyrem at the house. People don't listen. All right, we're out of here. Any questions about anything? I went over a little bit. All right.